All right, so I'm very sorry for the delay. Right. So I welcome you all to this particular session on the clinical based questions, right? Yeah. So yes, Gayaz Mohammed and yes, Zeenat Khan, good evening, and Madhubala, yes, the class have just started. Right. So now we are going to have a very interesting session now. So in this session, I have clubbed both. I have clubbed the image-based questions and I have clubbed the clinical-based questions in this session. Okay. So now let us start this session now with a very important image-based question. So the question is, right. So we have a 42-year-old man shown here, presents with fatigue and muscle weakness. This patient also may have all of the following features except thin, friable skin, hypertension, weight loss, acne, centripetal fat distribution. Yes. So who will answer this question first? Yes, Chandia, good evening. Yes, Shankar Deepu, good evening. Yes, so please answer this question. A 42-year-old man shown here presents with fatigue and muscle weakness. The patient also may have all of the following features except. Very good. So very good, GA. So the answer is weight loss. So first of all, can anyone tell me what is the diagnosis of this patient? Yes, what is the diagnosis of this individual? So this particular patient is suffering with what is called Cushing's. So whatever you are seeing here, right, whatever you are seeing here, they are nothing but the purple striae. Right, they are nothing but the purple striae. And along with the purple striae, what is that mentioned? The mention like there is fatigue, mentioned like there is muscle weakness. So this particular patient is highly suggestive of Cushing syndrome. In Cushing syndrome, they will have a thin friable skin. They will have systolic hypertension and diastolic hypertension as well. There will be also presence of acne. There will be also presence of centripetal obesity, but weight loss will not be there. What they will have in patients with the Cushing's? They will have weight gain. Right, they will have weight gain. So the answer here is C. C is the answer. Right, C is the answer here. All right, now we will move on to the next important image based question. Right, so if you see this question over here, the question says the skin lesions shown here developed in a 45-year-old man with hypertension after percutaneous renal angiography. Right, after percutaneous renal angiography. Complete blood count shows eosinophilia. What is this syndrome? Antiphospholipid antibody syndrome, warfarin necrosis syndrome, scleroderma renal crisis, hepatorenal syndrome, blue toe syndrome. Right, so what is the answer to this particular question? Right, so I could get answer from only one student. That is Adarsh Soni. So very good, Adarsh Soni. The answer is the blue toe syndrome. The answer is blue toe syndrome. See, let me give you the explanation of this. What exactly is the diagnosis? What exactly is the diagnosis? Okay, so even GA has answered, Adarsh Soni has answered. It is your blue toe syndrome. Okay, now why is that? See, after percutaneous renal angiography, right? After percutaneous renal angiography, atheroembolism, right? Atheroembolism is found to be seen in almost 30% of individuals, right? Atheroembolism is found to be seen in almost 30% of individuals after renal angiography. Okay, now secondary to this particular atheroembolism, what will happen once the emboli, once they go and get accumulated in the peripheral vessels, what will happen? The peripheral vessels, the extremities, right? The extremities, they will get reduced blood supply, right? They will get reduced blood supply. So that is the reason why you can make out that in the lower limbs, they are completely cyanosed, or you can see the appearance of the pallor, right? You can see the appearance of the pallor. So this is what is called as blue toe syndrome, right? This is what is called as the blue toe syndrome. So this particular history is very important. That is percutaneous renal angiography, because secondary to percutaneous renal angiography, there will be atheroembolism. Now, in atheroembolism, there will be also eosinophilia, right? And not only that, there will be also eosinophiluria, right? There will be eosinophilia or eosinophiluria will be there. Okay, so that is the answer in these patients. It is not scleroderma renal crisis. In scleroderma, what is that you will have? You will have the presence of very stiff or tight skin, right? Stiff or tight skin. Okay, so that is about the scleroderma renal crisis. But what is the answer here? The answer here is the blue toe syndrome. Now, we will move on to the next important image based question, correlating that clinically, right? Correlating that clinically. Yes. What is shown here? The shown is the urine sample. This is the urine sample, right? So shown is the urine specimen of 72-year-old man, right? 72-year-old man who recently underwent coronary artery bypass grafting with mitral valve replacement, right? With mitral valve replacement. He reports no pain. There is no pain. Which of the following is the most likely cause of the change in the urine color? Urinary tract malignancy, warfarin anticoagulation, nephrolithiasis, hemoglobinuria due to valve hemolysis, myoglobinuria. So what is the answer to this question? Very good. So yes, Gautam Nanda, Chandiya, right? Excellent. So the answer to this particular question is hemoglobinuria due to hemolysis, right? Hemoglobinuria due to hemolysis. So what does this particular patient has? This patient has what is called as blender effect. Right, this patient has what is called the blender effect. Now, what do you mean by this word blender effect? It is nothing but, see, what does the patient had now? There is mitral valve replacement which is being done. Now, secondary to this mitral valve replacement, there will be presence of the prosthetic valve. right? There will be presence of the prosthetic valve. And if there is presence of prosthetic valve, right, if there is presence of the prosthetic valve, when the RBC, when they are passing through that particular prosthetic valve, they can undergo rupture. There will be hemolysis. So once there is hemolysis, more and more hemoglobin, so there will be hemolysis. So secondary to this hemolysis, more and more hemoglobin, this is released into the circulation. Right, more and more hemoglobin is released into the circulation, and that will appear in the urine in the form of what is called hemoglobinuria. Right, in the form of what is called hemoglobinuria. Okay, so this hemoglobinuria is due to valve hemolysis. Right, it is due to valve hemolysis. Okay, now the next question is going to be another image based question, and that is going to be still very interesting question, right? And let me see how many of you will answer this. Yes, you see this question here. We have a 67-year-old man had a long history of hypertension, right? Had a long history of hypertension. Now that particular hypertension, yes, Gautam Nanda, the urine color, it is dark in color. Why? That is because of hemolysis. That is because of hemolysis. Okay, right. Now you see this question. 67-year-old man had a long history of hypertension. Now this hypertension is controlled with AC inhibitor and diuretic therapy. Now the point here is the ulcer shown, right? Let me show you the ulcer properly. Yeah, the ulcer shown here developed on lateral anterior shin and was extremely painful. Each of the following may be indicated in the care of the ulcer, except the options are narcotic pain control, smoking cessation, excision, addition of the beta blocker to the antihypertensive regimen, skin grafting. So the question asked is except, which one you should not do? What is that you should not do in this patient? So I'm waiting for the answer from any one of you. Right, so good, right? Everyone is answering here. Sai Taruni Danda, Chandiya, Satya Ver, right? Excellent. So the answer is one second. Right. So the answer is addition of the beta blocking drug to the antihypertensive regimen should not be done. Right? It should not be done. Now, what is this ulcer? Can anyone tell me what is the diagnosis of this ulcer? Yes, what is the diagnosis of this ulcer? Any one of you, please? What ulcer is this? Yes. So this is your, we have a terminology called Martinell's ulcer. Right? We have a terminology called Martorell's ulcer. Not Martorell, it is Martorell. Right? I'm sorry. So it is Martorell ulcer. Okay. Now this Martorell ulcers, these are seen secondary to hypertension. Right? These are seen secondary to hypertension. Now, where are they commonly seen? These hypertensive ulcers, they are located in the lateral supramalleolar margin of the lower extremities. So whatever is mentioned to you here, it is the lateral supramalleolar lesion. right? And where is it present? This is present over the lower limbs. This is present over the lower limbs. And what will be the character of the ulcer? It is a punched out lesion. Right? This is a punched out lesion. Now, these ulcers, why do they develop ulcers? First of all, you should understand why do they develop ulcers. And remember, these ulcers are extremely painful ulcers. Right? These ulcers are extremely painful ulcers. Now, the question is, why do they develop this ulcer in hypertensive patient? The reason is that these ulcers, they result from small artery and arteriolar narrowing. That is what is responsible. Arteriolar narrowing and occlusion. That is what is responsible for the development of this particular martorell ulcer. That is what is responsible for this martorell ulcer. That is ulcers that results from small artery and arteriolar narrowing and occlusion secondary to hypertension. So that history of hypertension is very, very important. Right? History of hypertension is very, very important in this particular patient. And if history of hypertension is not mentioned, then diagnosis of this question becomes very difficult. Now, in these patients, you can add ACE inhibitors, you can add the calcium channel blockers, but you should, and you can also give diuretic therapy, but beta blocking drugs should be avoided, right? Beta blocking drugs should be avoided. Now you see this question again. So 67-year-old man had a long history of hypertension, now controlled with ACE inhibitor and diuretic therapy. The ulcer shown here developed on lateral anterior shin and was extremely painful. Each of the following may be indicated in the care of this ulcer except. So you should not give beta blocker, right? Why? The question is why. Yes, Gayaz Mohammed, is that clear? You have asked me to repeat the question. So the reason is that the beta blockers, if they are being used in this patient, they should be completely stopped. Why? If possible, to allow maximum peripheral vasodilatation. If you give beta blocker therapy, that will not allow maximum peripheral vasodilatation. That will not allow maximum peripheral vasodilatation. So if beta blocker therapy is being used, it should be stopped if possible to allow the maximal peripheral vasodilatation. So that is the reason why the beta blocker should be stopped in these patients. And all others can be given, right? All others can be given. So narcotic pain control can be given, smoking cessation, stoppage of the smoking should be done. And you take the other options like excision of this particular ulcer also can be done, but administration of the beta blockers should not be done, right? Next, now followed by that, you see the next important question. Yes, so we have a 25-year-old man presents with 3-month history of crampy abdominal pain and bloody diarrhea, and a 3-week history of multiple red and tender lesions of the forearm. His past medical history is notable for low back pain and worsening in the morning. What is the most likely underlying cause for this skin condition? Sarcoidosis, psoriasis, Yersinia enterocolitica infection, medication-induced inflammatory bowel disease. Yes, DON-CNTES. Even alpha blockers are also contraindicated. You are correct, DON-CNTES. Even alpha blockers are also contraindicated in the above clinical condition in my previous question. Right, so answer this question here. Okay, good. So some of you are answering this correctly. Yes, very good, Jayapriya, Shankar Deepu, right? And Yamuna Vasudevan, Chandia, VS, all of you have answered it correctly. So the answer is inflammatory bowel disease. But I want to know the diagnosis. What is the diagnosis first of all? What is the diagnosis of the skin condition whichever is given? What is the diagnosis of this particular skin condition which is given in your slides? Right, so the answer to this particular question is, diagnosis is Erythema Nodosum. Right, the diagnosis is Erythema Nodosum. It is not Erythema marginatum, it is Erythema Nodosum. Right, yes, Srivastavan, Balaraman, it is not Erythema marginatum, it is Erythema Nodosum. Erythema marginatum, it is seen over the trunk, and Erythema marginatum is seen in patients with the rheumatic heart disease. Okay. Now what is this particular Erythema Nodosum and the story? Let me explain. So this Erythema Nodosum, it is a tender, red, subcutaneous nodules. Right? And where is it commonly seen? This Erythema Nodosum, it is very commonly seen over the pretibial areas. Right? It is commonly seen over the pretibial areas. And it is also seen over the upper limbs in the flexor compartment. Right? And there are many conditions which can cause this Erythema Nodosum. Now, these particular lesions, most commonly, where do you see this? In case of streptococcal pharyngitis. Right? You will see these lesions in streptococcal pharyngitis. And apart from that, Yersinia enterocolitica. Then histoplasma. Now, can anyone tell me what are the drugs which will cause Erythema Nodosum? Yes, can anyone tell me what are the drugs which are responsible for the development of the Erythema Nodosum? The drugs which are responsible for the development of Erythema Nodosum is the oral contraceptive pills and as well as the sulfonamides. Right, as well as the sulfonamides. So these are the drugs which are responsible for the development of Erythema Nodosum. Now, this Erythema Nodosum is also seen in connective tissue disorders like sarcoidosis, and it is also seen in Behçet's. Right, and it is also seen in inflammatory bowel disease. Right, also seen in inflammatory bowel disease. So these are all the etiologies where you will have this Erythema Nodosum. But this Erythema Nodosum, it is a tender, red, subcutaneous nodule seen in the pretibial areas, also seen in the flexor compartment. Right? Very commonly, it is seen in case of streptococcal pharyngitis, Yersinia enterocolitica, and histoplasma. And even connective tissue disorders, you have this, like example, sarcoidosis and Behçet's. And drugs which are responsible for the development of Erythema Nodosum include oral contraceptive pills and sulfonamides. Now, you see, actually you have all these in the options. Right? All these conditions you have in your options. But why did you select the inflammatory bowel disease? Anyone, please? All of these are there in your options, but why did you select inflammatory bowel disease? Anyone? Why? Because this particular patient has history of crampy abdominal pain, and this patient has the history of the bloody diarrhea, right? This is what is the reason you have to confirm the diagnosis as the inflammatory bowel disease, right? Yeah. So now we will move on to, these are your image based questions for today. Now we will move on to a purely clinical based questions. So please give me a thumbs up if you have understood these image based questions. And please tell me how are the quality of the questions as well. Just give me a thumbs up if you have understood all these questions, because we are going to completely purely clinical based questions. Right. So I'll revise all these images and then I'll move to the next clinical based questions. So the first image, what I have shown you for today was, this is the image, no, not this. Yeah, this is the image suggestive of the Cushing syndrome, right? This is the image suggestive of Cushing syndrome. And the next image, what I have shown you is, I have shown you the image of the blue toe syndrome, right? I have shown you the image of the blue toe syndrome. Then the next image, what I have shown you is the urine sample, which is dark in color, and that is secondary to hemoglobinuria due to valve hemolysis in this particular clinical condition, right? And the next image, what I have shown you is martorell ulcer secondary to hypertension. Martorell ulcer secondary to hypertension. Then the next image, what I have shown you is Erythema nodosum, right? This is your Erythema nodosum. Okay, right. Now this finishes clinical plus image based mixed. Now we will move on to, yes, you see this question. We have a 29-year-old woman referred to the diabetic clinic for poor diabetes management. She was diagnosed with type 1 diabetes mellitus at the age of 12 and prescribed actrapid insulin injections. Recently, the patient has been suffering fluctuations in her plasma glucose levels, and her previously well-controlled glycated hemoglobin has increased to 8.1%. The patient admits she has recently been avoiding using her injections. On examination, the patient has raised smooth lump that is firm on palpation at lower abdomen. The most likely diagnosis in this patient is worsening of diabetes, lipohypertrophy, injection scarring, lipoma, injection abscess. Yes, can anyone answer this? This is another very, very interesting question, and let me see how many of you will answer and who will be the first person to answer this question. Very good, Chandia. So Chandia has answered first, and excellent, Chandia. So the answer is lipohypertrophy. The answer is lipohypertrophy. Okay. Now, why not worsening of diabetes? Why not worsening of diabetes? Because you see, the previously well controlled, it has become 8.1%. Previously, it was well controlled, but now it has become 8.1%. Why not worsening of diabetes? Because if you take the normal HbA1c, it is less than 5.6. In diabetes mellitus, it will be more than 6.5. Now our patient, the HbA1c has become 8.1. Why not your first option? See, why not your first option is because the patient, he admits that she has recently been avoiding the use of injections. She is not taking the injections recently. Now, because she is not taking the injections recently. That is the reason why the HbA1c has become 8.1%. Right? That is the reason why the HbA1c has become 8.1%. Okay, so it is not worsening. It is because he has stopped. That is why the HbA1c has become 8.1%. Now, what is the point in suggestive of your lipohypertrophy? There is presence of raised smooth lump. The presence of raised smooth lump, which is firm on palpation at the lower abdomen. That is what is suggestive of your lipohypertrophy. Right? And it is not lipoma. Lipoma, it will be very soft in consistency, right? Very soft in consistency. And usually it is not seen over the lower abdomen, right? Usually it is not seen over the lower abdomen. And you take injection abscess. So it is the accumulation of the pus. The individual will be toxic. They will have a very high grade fever. Okay, and there will be all the signs of inflammation also will be there. Right, all the signs of inflammation should be there. Now, let me tell you, in diabetes, very good. So, Shravan Kumar has come up with a very good question. Let me tell you, Shravan Kumar, on repeated injections of insulin, so insulin injections, it can cause lipoatrophy in certain areas, and it can also cause lipohypertrophy. Both can be seen. Right? Both can be seen. Yes, Shravan Kumar, is that clear? Okay, so that is the reason why the answer to this particular question is lipohypertrophy, but not worsening of the diabetes mellitus. Yes, Adarsh Soni, the answer is not worsening of diabetes. The answer is lipohypertrophy. Yes, Shravan Kumar, if you have understood, just give me a thumbs up. Right. Now we will move on to the next important clinical based question. Right. This is going to be another very interesting question, and let me see how many of you will answer this question. We have a 15-year-old girl complaining of headache, which started 6 weeks ago. The headache initially occurred 1 to 2 times a week, but now occur up to 5 times a week. They are not associated with any neurological problem, visual disturbances, nausea, or vomiting. That means no neurology problem at all. The girl also reports the white discharge from both of her nipples. She has not started menstruating. What is the most appropriate investigation in her? Lateral skull X-ray, CT scan, MRI scan, thyroid function test, serum prolactin measurements. Okay, so I'm waiting for the answer. Who will be the first person to answer this question? Let me see. Very good. So Chandia has answered this. Very good, Chandia. And even Sankar Deepo also have answered. The answer is serum prolactin measurements. Okay. So what is the main important history here? The very important history is headache. And the other important history is white discharge from both of her nipples. White discharge from both of her nipples. So what is this suggestive of? This is suggestive of hyperprolactinemia. This is suggestive of hyperprolactinemia. Then why is this headache then? Why is this headache? The headache is due to the reason that this hyperprolactinemia, it is due to, right, this hyperprolactinemia, this is due to pituitary adenoma. right? It is due to pituitary adenoma. And what type of pituitary adenoma here? Now, because there is no visual disturbances. If there is no visual disturbances, what does that mean? There is no compression on the surrounding structures. Now, because there is no compression on the surrounding structures, this should have been a microadenoma. Microadenoma means the size of the tumor will be less than 10 mm. Right? Microadenoma means the size of the tumor, it should be less than 10 mm. That is what is your pituitary adenoma, that is microadenoma. And because of this microadenoma, there is raised intracranial pressure. And because of this raised intracranial pressure, the individual is having headache. Okay, so when you are suspecting prolactinoma, remember always the most appropriate investigation will be serum prolactin measurements. And followed by that, you need to do MRI scan. Why you have to do MRI scan? The purpose of doing the MRI scan is mainly to look for the size of the gland. Right? In order to mainly look for the size of the gland, you have to do MRI scan. Okay, so whether it is microadenoma or macroadenoma. Microadenoma means less than 10 mm, that is less than 1 centimeter. Macroadenoma means more than 1 centimeter, that is more than 10 mm, right? So that is what is the difference between your microadenoma and macroadenoma. And the best answer here will be what? That is serum prolactin measurements. Okay, right. Now we will move on to the next question. Yes, this is another very interesting question, and let me see how many of you will answer this. We have a 7-year-old girl presents with red striae, which her mother noticed around her abdomen. The girl also has plethoric cheeks, and on her back, several faint, irregular brown macules are observed. The mother is particularly concerned about the early breast development that seems apparent on her daughter. Serum phosphate is decreased. The most likely diagnosis of this patient is Paget's disease of the bone, McCune-Albright syndrome, Cushing's disease, hypopituitarism, neurofibromatosis. Yes, who will be the first person to answer this? Okay, so very good, VS. So VS is the first person who has answered this. The answer to this particular question is McCune-Albright syndrome. Right? The answer to this particular question is McCune-Albright syndrome. Now, why is it McCune-Albright syndrome? Let me explain you in detail about the McCune-Albright syndrome. So, McCune-Albright syndrome, it is one of the genetic disorder that causes the uncontrolled secretion of a number of endocrine glands causing abnormalities in the skin, right? There can be abnormality within the skin. What is the abnormality in the skin here? There is presence of the red striae, right? And apart from that, there can be also abnormalities within the bone, and there will be also hormonal disturbance that can be seen in these individuals with the McCune-Albright syndrome. Now, these patients with the McCune-Albright syndrome, they will have what is called a precocious puberty. Now, what is the point in favor of precocious puberty in this patient? You see here, there is concern about early breast development, right? She's just only 7 years old. So 7 years old, how can you expect the breast development, right? That will not be there. So there will be a precocious puberty in these patients with McCune-Albright syndrome. There will be also Cushingoid features, right? And there will be presence of the CAFU spots. Right, there is presence of CAFU spots. Now, what are the points in favor of your CAFU spots? So, the points in favor of your CAFU spots is irregular brown macules. Right, irregular brown macules, they are observed. on the back. That is what is suggestive of your CAFLU spots. And these individuals, let me tell you, in McCune-Albright syndrome, they will have hypophosphatemia. Right? They will have hypophosphatemia. Okay, so that is the reason why. Now, even the question also, what does it tell you? It tells you that the serum phosphate is decreased. So that is what is your McCune-Albright syndrome. It is not your Cushing's syndrome. What are the points which are going against your Cushing's disease? Early breast development, not seen in Cushing's. Serum phosphate decrease, not seen in Cushing's. Okay, and in Cushing's, you will not have red striae. What you will have in Cushing's, it is the purple striae. Right, it is the purple striae. Now, coming to the Paget's disease of bone. Now, why not Paget's disease of bone? Right, why not Paget's disease of bone? Let me explain. Because one of your option is Paget's disease. So Paget's, it is the disease of the bone, and usually they present with bone pain. They will have hearing loss, and they will also have deformities of the bone. Right, they will also have the deformities of the bone. So in our patient, there is no hearing loss, there is no bone pain, there is no deformities of the bone. So that is the reason why your Paget's disease of the bone is ruled out. Right, Paget's disease of the bone is ruled out. Whereas you take in case of the neurofibromatosis. Now, what does this neurofibromatosis represent? The neurofibromatosis, it is the genetic disorder that causes the tumor growth of the nerve tissue. Right? Tumor growth of the nerve tissue. Now, these patients with neurofibromatosis, they can present with learning difficulty. They present with absent seizures. They present with features secondary to impingement by the neurofibromas. Like what is that? They will have the features like headache and deafness. And they will have these CAFLU spots. They will have these CAFLU spots. So in our question, clinical question, whichever is mentioned, the point only in favor of your neurofibromatosis is CAFLU spots. There is no other point in favor of your neurofibromatosis. Okay. Now, in neurofibromatosis, the other skin manifestation is very important is presence of axillary freckling. Right? Presence of axillary freckling. That is another point in favor of your neurofibromatosis. So, do we have the point features favoring neurofibromatosis? No. So that is the reason why it is not neurofibromatosis. Okay, right. So this is about this particular clinical question. Now we will move on to one of the last important question, right? Last one more question. Because as you people have asked me yesterday, sir, please increase the number of questions to be discussed. And today I have discussed almost 9 questions. This is the 9th question what I am discussing now. The one which I am discussing today is the 9th question now. Okay, so compared to yesterday, I think yesterday we have discussed 6 or 7, right? I have increased the number. So mainly, and the other request what you people were asking me is to incorporate the image based questions. So what I have done today, I have incorporated images along with a clinical base, right? So that is what I have added in this session. Okay, now, and I just want to ask you one more thing. Did you receive the notes? Yesterday I have sent the notes to the today I have sent to the staff of this Arise Medical Academy. So did you receive the notes of the yesterday's class? Yes, did you receive the notes of yesterday's class? Okay, so those students who did not receive can contact Shaibaz in Arise Medical Academy. So you will be getting the notes from him. Already I have sent to him. Right, good. Now we will move on to the next question, the last question for the day. Last question for the day. Okay, so the question is, A 18-year-old man presents to the clinic worried about his scant pubic hair development. Examination reveals undescended testes and plasma testosterone, luteinizing hormone and follicle stimulating hormone were found to be low, right? Were found to be low. A karyotype test was 46XY. The patient was otherwise well, but during neurological examination, struggled during the olfactory test. What is the most likely diagnosis in this patient? What is the most likely diagnosis of this patient? Oh, very good. So Sai Tarni has answered, Dr. Mohan answered, Santhia Ver, everyone is answering. Very good. And those students who did not answer Kalman syndrome, please remember the diagnosis of this patient is Kalman syndrome. The diagnosis of this patient is Kalman syndrome. Now, what is Kalman syndrome? Let me explain. So Kalman syndrome, it is one of the rare genetic disorder which results from deficient hypothalamic GnRH, right? Which results from deficiency of hypothalamic gonadotrophin releasing hormone. And once the GnRH is reduced, what will happen? There will be reduction in the FSH and as well as there will be reduction in the LH from the pituitary, and that will make the individual to land up in the hypogonadism. Right, that will make the individual to land up in what is called hypogonadism. Okay, so not only hypogonadism, there will be also infertility. Okay, and there will be variable pubertal maturation. If you see in our question, the maturation did not occur still. So there will be variable pubertal maturation in Kalman syndrome. Now the question is, right, the question is, why not Klinefelter syndrome? See, Klinefelter syndrome, what is their genotype? 47XXY. What is given in our question? The genotype given is 46XY. So that is the reason why your Klinefelter syndrome is ruled out, right? So otherwise, Klinefelter syndrome, let me tell you, it is the most common chromosomal abnormality associated with the hypogonadism. It is the most common chromosomal abnormality associated with the hypogonadism. Now, the question is, why not your option A, right? That is hypogonadotrophic hypogonadism. Why is it not A option? Why? Because now what is the additional test mentioned? The neurological examination struggled during the olfactory test. Right? Neurological examination struggled during olfactory test. So what does that mean? That means that the patient has anosmia. So this anosmia will not be there. In hypogonadotrophic hypogonadism, that will not be there. Okay, so because anosmia is not there in hypogonadotrophic hypogonadism, that is the reason why your first option is ruled out. Right, your first option is ruled out. Otherwise, you will have all other features, whatever is there in the question. But anosmia will not be there. So anosmia is characteristically seen in patients with the Kalman's. Right? It is seen. Anosmia is what? Loss of sensation of smell. Right? Loss of sensation of smell. Now, what about the other options? You take this androgen insensitivity syndrome. So if you take this androgen insensitivity syndrome will cause female phenotype, right? Will cause female phenotype with male genotype, right? With male genotype. And this is due to X-linked recessive abnormality. Right? This is due to X-linked recessive abnormality. Okay, so what will happen in androgen insensitivity syndrome? The individuals fail to develop their external genitalia. Right? In androgen insensitivity syndrome, they fail to develop external genitalia. Why? That is due to poor sensitivity to androgens. Right? So due to poor sensitivity to androgens, these individuals, they will fail to develop the external genitalia. So that is the reason why your androgen insensitivity syndrome is ruled out. Why? Because the individual will have female phenotype with male genotype. But what do we have in our patient? In our patient, he is 18-year-old man. That means what does he has? He has the male phenotype. It is not the female phenotype. Male phenotype is there and male genotype is also there. But in androgen insensitivity syndrome, you will have male genotype and female phenotype. Now, what about the other option? You take the 5-alpha reductase deficiency. How do you rule out this? What is this enzyme? Let me explain. So if you take this 5-alpha reductase deficiency, this will lead to so because of the deficiency of this enzyme, this will lead to deficiency of dihydroxytestosterone. Right? This will lead to deficiency of dihydroxytestosterone. Okay, so because there is deficiency of dihydrotestosterone, genetically male patients are only affected. Right? Genetically male patients are only affected. And what will be the features? Such patients usually appear female, although they are born with the male gonads. And in 5-alpha reductase deficiency, smell is not affected. Right? In 5-alpha reductase deficiency, the smell is not affected. Okay? Right. So the answer to this particular question is what? The answer to this particular question is Kalman syndrome. Right? It is not your any other options. So how do you rule out the other options? Hypogonadotropic hypogonadism, there is no anosmia. Klinefelter syndrome, the genotype is 47XXY, but what is given in your question? That is 46XY. Androgen insensitivity syndrome, why is this ruled out? Because in androgen insensitivity syndrome, you will have male genotype and female phenotype. What is given in our question? Male genotype and male phenotype. 5-alpha reductase deficiency, why is this ruled out? Because there is no anosmia in these patients. So that is the reason why first 4 options are ruled out. The answer to this particular question is the Kalman syndrome. Okay, so with this, I will wind up the today's session. So please let me know if you have any doubts in the today's session. Right? And I will be sending these questions to the Arise Medical Academy staff and they will send you. Right? So only those students who are there in Arise Medical Academy will be getting these particular notes. Right? So you can contact to the staff of Arise Medical Academy to get these particular questions along with the explanations. Okay, right. If you have any questions, then you can ask me, and please tell me how was the session. So how was the session? Can you just give me a feedback on this? So because that will be helpful for me, because yesterday you have asked image-based questions. Yesterday you have asked to increase the number of questions. So that is the reason why today I have increased the number of questions, and today I have also increased the image-based questions also in your session. So like that, if you want to give me any feedback, I'll be very happy to take your feedback. Yes. Okay. So, right. Yeah, yes, Santosh, what is the management of the Cushing syndrome? Okay, Santosh is asking a question, what is the management of the Cushing syndrome? See, in Cushing syndrome, the treatment of choice is surgical resection of the tumor. Usually Cushing syndrome, it is either due to pituitary adenoma, that is corticotroph type of pituitary adenoma, or the Cushing syndrome, it would be due to adrenal adenoma or the adrenal carcinoma. The treatment of choice is surgical resection of the tumor. But in those individuals who are not fit for surgery, them you need to give ketoconazole. Ketoconazole, it is a drug which will cause medical adrenalectomy. Yes, Santosh, is that clear? Right. So with this, we will wind up the today's session now, and then see you again in the tomorrow's session. Okay. Right. Thank you very much. Good night. And the very important thing is, please inform to all of your friends. And these are the type of questions which you will be getting in your FMGE December session. Right. So what is our main aim here? Our main aim is to see that you should not feel any question in the general medicine difficult. So for that reason, in Arise Medical Academy, we have planned to do a separate series of clinical based questions. This will be done all through the month, right? This will be done all through the month. So please inform to all of your friends as well to take the advantage of these particular sessions, and then this particular December exam should be a very easy exam. Whatever might be the number of images, whatever might be the length of the question should not scare you in this month of December. So with that motive, we have started the clinical based questions from Arise Medical Academy, right? So please take the advantage of these sessions, right? Read well, revise well, be confident, don't go into a state of depression. And all these failures, whatever we are getting now, these are completely a stepping stones of our future success. That is what your attitude should be whenever you are preparing for your exams, right? So with this, I will just wind up the today's session, and tomorrow again at the same time at 7 p.m. we will reassemble back and discuss some more image based and as well as the clinical based questions. Okay, so thank you very much. Good night.